All right, so welcome guys. Welcome to I think the fourth webinar session that we've been having, and it's basically a repeat of the previous webinar we had for those who weren't able to attend. It's focusing on STEMIs, primarily the acute coronary syndromes, and just reviewing the pathophysiology, reviewing the clinical manifestations, and just a little bit more in depth on how it kind of manifests and a little dive into the physiology of it all so you can kind of gain a better appreciation to how STEMIs kind of form and also what to look out for. So for me, I work with a state service. I've been a paramedic now for 3 years and I just enjoy educating. Definitely something I want to look forward to in the future is going to more educational role, but that's not for another 5 years. But until then, I just enjoy sharing my knowledge and helping you guys, especially if you're at university, just to supplement your learning needs. So the goals for today is four things. It's actually five things, but two mainly to build your understanding of STEMIs, your heart attacks, and a revision of the following 4 points in relation to STEMI. So what is a STEMI? How do STEMIs actually occur? So the pathophysiology and what things to look out for when we're suspecting someone is presenting with a potential heart attack or they got ECG signs associated with a STEMI. And also just a brief clinical management. I know quite a few of you don't live in Australia. I know a lot of people have variations in clinical practice and protocol, so I don't dive into the exact management. I would ask you to refer to your own clinical guidelines when it comes to that. But I can give you just some general outlines and what you should at least consider when you're going to these kind of patients. You can include this in your CPD portfolio. Last, I will let you know, last webinar went for 2 hours, so it will count for whatever time we finish. But you can add this to your CPD portfolio if you're in Australia or if you'd like to use it. Here's kind of the brief guideline on how you can implement it. If you want to use it, just send me an email and I'll give you a certificate of completion at the end of this webinar. So we've got a lot to cover. I'm just going to go straight into it. I always find when discussing about STEMIs, discussing about the heart, we need to kind of look at what exactly is the system that we're reviewing and what is its purpose in the human body. So the heart, the main subject of our topic is part of your cardiovascular system. I always say cardio, the heart is the pump that kind of allows the circulation to actually be pushed around the body. And the vascular, the vessels, so your arteries, your veins, they are the pipes that bring oxygenated blood around the body and also brings back deoxygenated blood, waste products, back to the heart, back into the lungs, and then expelled. The importance of the circulatory system is kind of threefold. I kind of talk about it more. It's not just bringing oxygenated blood, but that's also the bigger part of it and what we're actually looking at when it comes to how it impacts the heart when we don't get enough oxygenation to it. But one of the big ones is oxygenation. So it brings oxygen to all the cells in the body. We need it for ATP. We need it to basically exist and function as organisms. It also brings hormones and nutrients around the body, and it also acts as immune response and allows us to bring, if there is a bleed somewhere, it can bring clotting factor involved, and as well as that, it can regulate temperature. Because one of the waste products of ATP, of energy production, is temperature, and so circulation allows us to bring that heat away and modulate that. If we get too hot, there's a few things that the body can do. But the bigger point I like to say is oxygen. That's probably the main part of this whole topic is that when we don't get enough oxygen, especially to the heart, it really affects our ability for ATP generation. And again, it's through oxidative phosphorylation. We won't dive into exactly how ATP is done, but to get a glimpse of it, we need oxygen for ATP. ATP is essential for basically all functions and for the cells in the heart to function properly. And we will talk about ATP gated potassium and sodium channels and how when we don't get oxygen, they get affected and in turn, they then exacerbate the situation. really brief run view on the blood flow. When we're talking about the heart, we're talking about its role as a pump. We look at the superior vena cava, so really brief overview, and the inferior vena cava. And essentially, these bring all the deoxygenated blood back into the heart. It also brings waste products, so carbon dioxide, and it takes it to the lungs. So it all heads into the right atrium. So this is your RA. And just a little bit of a note, these valves that we have here, there's 4 valves, and the main purpose of the valves is to keep blood flow going one direction. Really can't have blood flow going the opposite direction, as that causes a backlog. In certain cases, especially if it's mainly an issue with backflow in, for example, the left ventricle, you're going to have fluid buildup in the lungs, and then you get your APO manifesting. But all the deoxygenated blood starts off in the right atrium. In the process of contraction, and the cardiac myocytes contract, all that blood in kind of a controlled manner gets pushed into the right ventricle. And this, especially the ventricles here, these chambers, they're much larger. They have a lot more muscle involved when it comes to contracting. And you will notice the left one here, the left ventricle itself is quite big in comparison to the right ventricle. And that's because the left ventricle is pumping all that blood, which is oxygenated, around the body, and the right ventricle is pumping deoxygenated blood into the lungs. So it doesn't need as much force to get that blood into the lungs, whereas the left ventricle really needs to have a big squeeze to kind of get that circulation to the legs, to the head, to the arms. Once it goes down into the right ventricle, it then shoots up into what's called the pulmonary veins. When we talk about veins and arteries, sorry, pulmonary arteries, because when we're talking about the vessels themselves, veins go away, veins go towards the heart, and arteries go away from the heart. So because this is going away from the heart, we call them the pulmonary artery, and it goes into the lung, and that's where you get your gas exchange. That's when the carbon dioxide gets removed, oxygen comes in through the alveoli in your gas exchange, and then it returns through what's called, and you don't really have it here, but it returns through the pulmonary veins. So circulation returning back to the heart. And where the veins go into is your left atrium. And from there, it simply gets pushed down into your left ventricle. And then it gets squeezed out in a big contraction into your aorta. And this goes into your brain, it goes into your body, into the lower legs. And this is actually an important aspect of it, because we mentioned in the earlier webinar about strokes, is where the actual stroke forms is important, because in the case of atrial fibrillation, where the ventricles or the atrium is fibrillating and a blood clot forms, if the blood clot forms in the left atrium, it's going to travel into the left ventricle and it's going to get pushed out into the aorta. And that's where you're going to get your brain, the clots in the brain, you're going to get your strokes, because that's going directly to the brain. Whereas in your right atrium, where that clot forms, it's going to travel into the right ventricle. And where's that going to go? It's going to go straight into the lungs. So generally speaking, when it forms in the right atrium, it's going to cause an embolism, a pulmonary embolism into your lungs. And there's the same thing about DVTs, so deep vein thrombus. When a clot forms there, it's going to travel back to the heart. And we can see that any form of circulation that's returning to the heart, it's going to go back through the superior or inferior vena cava, is going to go into the right atrium. And again, that's going to cause your pulmonary embolism. So we don't really, when we think of DVTs, we don't really think of them as causing strokes, but we're more concerned with them causing a lung clot or an embolism. So that's just a bit of good to know. These are the arteries. We're not going to go into depth, but we will connect them into the different parts of the 12 lead and how the 12 lead kind of covers these arteries. But essentially, any form of occlusion to these arteries that perfuse the heart is going to lead to ischemia. It's going to lead to infarction. And of course, we may see the ECG changes in what's known as a STEMI criteria. Not really important. You can take a photo if you want, but that's just a quick rundown of those. But the bigger part is, so now we know how circulation works and essentially the role of the heart is to be a pump. We need to figure out how does it actually allow the pump, because it's not just pumping by itself. It needs something to allow the muscles to contract. And that's when we go to our electrical pathway of the heart. So when we're talking about it, and again, I understand some of you are in your first year or thinking about doing paramedicine, so haven't really built the foundations yet. I try to keep this as simple as possible. For the blood to flow, the heart must contract. If it's not contracting, it's dysfunction. It's going to lead to a range of problems. You have your heart failures when it doesn't work properly. But for it to contract, you need to have some form of electrical impulse that drives this contraction. And we call this the conduction pathway, but it can't be in any direction. The way blood flow, if you look at the actual heart diagram, the right atrium is at the top and the right ventricle is at the bottom, and the same thing with the left atrium and the left ventricle. It needs to contract in a way that it's pushing blood in one direction, and that's kind of how the electrical pathway is set. So it's usually what's called at the apex of the heart, and it goes down. The electrical pathway goes down from the right atrium. It kind of stimulates both the right and left atrium simultaneously, and then it goes down to the ventricle. So it's a very quick process, but basically it goes from the top of the heart to the bottom of the heart. And before we look at the diagram, I will just quickly outline the two main cells that are in the heart, and we're going to be looking at the myocardial cells, which is what is the main patho when it comes to the STEMI criteria. But the myocardial cells, their main goal is they allow for rapid conduction of electrical impulses from one cell to another. And essentially, there are three main ions that we focus on when it comes to the action potential, and that is your potassium, that's your sodium, and your calcium. All three are positively charged, and we'll talk about how the movement of these creates a negative charge and allows for the heart to essentially contract. But the big part of the myocardial cells is that they have the ability to contract and relax, because these have what's known as fibrils, and they allow essentially contractivity of the myocardial cells, and they are about, I think, 85 to 90% of the mass of the heart itself. So that's all the muscle around the heart and essentially what is needed for blood flow to contract. As I mentioned, in the atrial walls, far less in terms of thickness compared to the ventricle walls, because again, the ventricles have a larger role in pushing blood into the lungs, into the outer body. Now look at our pacemakers very briefly. Electrical conduction system, they are responsible for providing spontaneous electrical transmissions from the top of the heart down to the bottom. And that is what we get in terms of our heart rate. So the pacemakers, they dictate, especially in the sinoatrial node, they dictate what the baseline conduction system is. So when we're looking at, for example, a pulse oximeter or 12 lead, and we're seeing the number such as 100 beats per minute or 60 beats per minute, that is representing how many times the pacemaker cells are generating electrical impulses. Please let me know if I'm going too fast, but I'm just providing a quick overview of electrical pathways so we can kind of go into the main part, which is the kind of how the cells create the representation of STEMIs. But this is your diagram of the heart again, but this time I'm just going to quickly outline what the electrical pathway is. And let me just change this into a pen, and if I can change the color of that. Okay, perfect. So electrical conduction starts around here. So kind of around your right atrium. And this is what's known as your SA node. Okay, that's your intrinsic natural pacemaker of the heart. And from here, it travels down, the electrical pathway kind of travels down into what's known as your AV node. From here, from the AV node, it actually slows down the electrical kind of conduction pathway, and it slows it down ever so gently. But then from here, it goes down to what's known as your bundle of Hist. And it branches into your left and your right bundle branches. And these go all the way down into your left and right ventricle, into what's known as your Purkinjeal fibers. And this whole process here is allowing a stimulation of the myocardium. And at this point, when an impulse generates in the SA node, it travels to both the left and the right, goes down, goes into your ventricles. And at that point, as it's coming through, you get what's known as your QRS, which is represented on the ECG. So the ECG in your 12 lead is really just looking at how the electrical system is working in a normal working heart. When the S8 node generates an electrical impulse, it's going to go into both your right and your left atrium at the same time, and it's going to create what's known as a P wave. So this represents your atrium contracting, or basically your atrium. How am I going to write this? This represents atrial depolarization. And as it travels down into the AV node and enters into the ventricles, this part here, your QRS, that is now your ventricles depolarization. And the reason we don't see in the next part the atrials repolarizing is because it's actually hidden underneath the ventricles depolarization. So we don't actually get to see the electrical representation because the current generated by the QRS, generated by the ventricles depolarization, masks the atrial nodes kind of resetting. So somewhere around here in your QRS is your atrial repolarization. And then here is your ST segment, really important. This is the part we're going to really look at later on. But there's kind of a little bit of a plateau before you have your ventricle repolarization. And so when it comes to the ECG, if we look at a certain lead, so you have your lead 1, lead 2, your V1 to V6, these leads, they're not actually telling you how well the heart's contracting. You can kind of get a gauge of it, but it's really just looking at how is the electrical conduction working in this specific area of the heart. And so we often see here, and it's a reason why when we have certain abnormalities, we're not seeing it in the entirety of the 12 lead. We're seeing it in only certain leads, which is why we can kind of pinpoint which arteries are potentially being affected and which part of the heart is having some form of ischemia. So if we look at lead 2, which is generally lead 2 is your what we call our rhythm lead. So when we print out a 12 lead, we're going to be looking at lead 2 to determine what the underlying rhythm is, and that's purely because where it sits in the grand scheme of things in lead 2 is right at the bottom of the heart in terms of the electrical conduction pathway. So we actually see a full kind of the process of it. So it gives you probably the cleanest look of how the electrical conduction system is working in that particular moment, which is why we often use lead 2 as our rhythm determiner. But we will look at that again. So essentially, electrical conduction, as it's generating an impulse, it's creating a chain event where essentially, as it travels down the heart, it's contracting the atriums, which pushes blood into the ventricles. And as the electrical pathway goes down into the ventricles, it's going to contract then the ventricles and push blood. We really can't have it the other way around because again, if the ventricles are pushing um, first, you don't have any blood in them. We need to have the blood going one direction in order to again perfuse the body. So the 12 lead, again, this is mainly STEMIs, but your 12 lead is a diagnostic tool. We can use it to assess for signs of atrial fibrillation, ventricular tachycardia, all these different kind of ECG presentations. We can use the 12 lead to get an idea of. And all it is doing is it's capturing the electrical activity of the heart. And we represent that with the graph paper. So your ECG, when you print it out, that's really just looking at how the electrical system is working. And we have two different kind of areas. We have the V1 to V6, which views the horizontal plane. So this goes around the front of your chest. And then we have your limb electrodes, which when combined together create 6 leads that view the vertical planes. So the ones you put on your shoulders and around your waist, those are your limb electrodes. And this is what allows us to get a full picture. And it kind of, as a lot of people would say, when we put this all together, it's giving windows of the heart. It's allowing us to peek through certain areas and seeing if there's something that's going on. And again, we really can't be doing a 4 lead or 3 lead with these patients. If they have chest pain, you need to do a full 12 lead to get a full appreciation of what's going on. Very briefly, your limb leads, with the way they are presented, they will always generally, when it comes to depolarization and repolarization, because if we look at negative to positive, it's generally going the electrode that we're looking at. It's going to have a positive direction. So when we look at, I'm just going to, so when we look at depolarization, and this is probably a very important thing to be aware of before we continue, and repolarization. If we have, and this is whatever lead that you're looking at, lead 1, lead 2, V1 to V6. If we have depolarization that's going towards the lead that we're looking at, it's going to create a positive deflection. So it's going to create a bump upwards in the electrical graph. And if we have depolarization that goes away from the lead, it's going to create a negative. It's going to create a negative deflection. And we looked at the 12 lead and how it kind of creates the that's a really bad graph, but we look how the atrium creates when it depolarizes a positive bump. If we remember the heart itself, it's going down. And if we have the lead that's looking at it, the depolarization is going towards the lead that's looking at the electrical activity. So we're going to get a positive deflection, and that's why the P wave is positive for most leads, or for all leads actually. But when it comes to repolarization, if it's going, and it's essentially the opposite, if it's going towards the lead, it's going to create a negative deflection. And if it's going away from the lead, it's going to create, oh, sorry. So wrong way, same kind of thing. If it's going towards it, it's essentially the same, but going away. So really, that's all you really need to know when it comes to depolarization and repolarization, is that anytime it's going towards the lead that's watching it, it's going to create a positive bump. And if it's going away, it's going to create a negative bump. And the only lead that has a negative QRS as a baseline for normal heart function is your AVR, and it's going to create a negative deflection, where all the rest of the limb leads are going to have a positive deflection. So you will notice in your QRS when you're looking at the AVR, it's going to be mainly pointing downwards, but that's normal for most patients. So as I mentioned, all these leads are generally positive, where the lead is actually looking at these parts. So they're going to create a positive deflection with your QRS, your P waves, and your T waves. But here in the AVR, because it's the lead's naturally facing away, it's going to create a negative deflection here. So it's going to be down. So you're not too concerned. In fact, a way to figure out whether you placed the leads right is by looking at your AVR. If the AVR is positive when you do the 12 lead, just double check that you placed all your electrodes properly. When you're looking at the 12 lead, it's separated into key parts that allow us to kind of separate and to kind of funnel down what part of the heart has been affected. And we talk about here the inferior portion of the 12 lead, and we have your septal, and we have your anterior, and then here we have our lateral. So the grays here is what's known as your low lateral, and then your up here is your high lateral. And essentially, what we're looking for is trying to pinpoint where in the 12 lead is showing signs of a heart attack. And we will notice generally when it comes to it, it's going to be isolated to certain areas. Again, if there's multiple arteries that are being infarcted or they have an occlusion, it's going to create changes in multiple leads. But for example, if you have a STEMI that's showing in your V1 to V2, and it's also reaching down to V3 to 4, you generally call it the septal anterior or anterior septal infarction. Terrible writing here. And then, for example, if there's an infarction in your lead 1 to lead 3 in AVF, you're going to have what's called an inferior STEMI. And the same thing with your high lateral and low lateral. This is kind of a post I made a couple years ago around these kind of 12 leads, and you can kind of, I guess, you just kind of memorize the affected vessels involved. So when we're looking at V2 and V1 or V1 to V4, and we're seeing ischemic changes in those specific areas, we can then be suspicious that the arteries that have been affected could be your left anterior descending or your proximal LAD. In the same kind of sense, if it's infarcting in your lead 2, lead 3, we can be suspecting a potential left-sided right coronary artery or left coronary artery involvement as well. But all the leads, as I mentioned, is viewing specific areas of the heart and allows us to get kind of a picture of how the electrical system is working. Because when the heart is having an issue with oxygenation, the electrical pathway in those particular areas is being severely affected, and that's why when we're seeing changes in the morphology of the 12 lead, it generally could be an indication that at that specific area of the heart, it's not getting enough oxygen, the electrical conduction is not working, and then we can probably say, oh, you might be having a heart attack. Uh, But it's not to say, in terms of what I've just said, it's not a be all end all kind of thing, because again, we will talk about there are mimics to STEMIs. It's not telling you that it's got a full occlusion, it's got a partial occlusion, it's got like a 25%. It's just telling you that the electrical pathway is not doing the right thing when it comes to the 12 lead. Which is why we can't be fixated all the time that just because it's elevated, it means it's STEMI. Again, if there's certain parts of the left ventricle, for example, that has a lot of tissue known as hypertrophy, it can create what looks like a STEMI criteria as well. So it's not just saying that it's a STEMI or like it's just saying that it's a heart attack. It's purely saying that there's something going on electrically, and we need to get it investigated. Any questions so far? You guys are all unmuted, so you can talk if you think I'm going a bit too quick. But I just really want to review the cardiac action potential, and this is the part that kind of gets a lot of people kind of mixed up. But this action potential, and we're only looking at the ventricles when it comes to it. This is the process of the myocardium contracting. And it's really important that this whole process is done, because without this process, and when we have ischemia or something that affects it, the cardiac myocytes simply do not perform its function of contracting, and you end up with an inability of blood to pump around the body, and you have what's known as hemodynamic compromise and eventually cardiac arrest. So let's see. Okay, So it's in 4 phases, but it starts up with 4. So it's not like 1, 2, 3, but this is your what's called your resting action potential or membrane potential, either one. And it generally starts at 90 minus millivolts. At this point, in number 4, there is no contraction of the ventricle. So the myocardium is at that time at a resting phase. It will always be at around 90 millivolts purely because that is generally what the cardiac cells are. They are naturally negative, and a process generally caused by an electrical activity stimulated by the pacemakers. So when a pacemaker cell generates an electrical impulse, it's going to start a chain reaction in all the other myocardial cells to start contracting as well. So this pacemaker cell kind of kickstarts the process. And what it does is it allows a little bit through what's known as gap junctions, allows a little bit of positive sodium and potassium to come into the cell, and it pushes to what's known as minus 70 millivolts. From here, in minus 70 millivolts. At that point, you have what's called an opening of voltage gated sodium channels. So in here, at this point, at minus 70, it opens the door for these voltage gated sodium channels. So that only at any point it will remain closed, but once it reaches the threshold, sodium channels open up and sodium comes in. Now, because this is minus 90 millivolts or minus 70 volts, you have a massive influx of sodium, which is positively charged. It's going to go into the cell and it's going to push it up all the way to around 20 or 30 millivolts. So it's going to make the cell positively charged. And at this point, the sodium channels close. So that's why it peaks here. And at the same time that the sodium voltage channels are closing, you have there's 2 main channels that open up when the sodium channels close, and that's your potassium and that's your calcium channels. So when this closes, you have 2 things happening. You have potassium, so K plus, going out of the cell, and you have calcium, which is positively charged, going into the cell. The reason why we have kind of what's called the initial depolarization phase is because whilst potassium and calcium open up after the sodium channel is closed, potassium channels open up quicker than the calcium channels. So the calcium channels take a little bit longer, not too long, but just a little bit longer for them to open. And what happens is you get a little bit of a slope downwards, and then you get this plateau. And this is your And the reason why it's a plateau here is because the amount of potassium, which is positively charged, that is leaving the cardiac cell is about equal to the amount of calcium that's going into the cell. So even though we're losing a positively charged ion and we should be expecting the cardiac cell to go negative, because calcium, which is positively charged, is coming in at the same time, you get a net charge of 0 that's being lost during this point. And it's actually the calcium that's responsible for contraction. And we really need calcium to come in during this phase to allow the cardiac myocytes to contract and allows all the ventricles to do the job it needs to pump blood around the body. At some point, around 200 milliseconds is when this period kind of lasts for. The calcium channels do then shut off, and there's no more calcium that goes into the cardiac cell. And because calcium is closed, you still have potassium that's coming out. And it will continue to come out until it reaches back to its minus 90 millivolts. That's your resting action potential. That's the point where we want the cells to go back into. and then it's ready for another set of electrical impulses to trigger again another contraction of the myocytes. And the reason and the way it stays at minus 90 millivolts in this phase 4 part is with the help of ATP, potassium, and sodium channels. And at this phase, in phase 4, you have with these ATP channels, you have them moderating it to maintain a minus 90 millivolts. So it's kind of moving potassium out, moving potassium in, or moving it out, and so with the sodium, and that helps it keep it at that state until the next electrical impulse. And this is the part that causes a lot of grief when it comes to STEMIs, because this here, when we have an issue with ischemia, the ATP gated channels that help modulate or moderate this flow of potassium and sodium, they no longer work. So you end up with something that affects this phase 4 um, at a time where the myocyte should not be contracting. And this is, again, there's a label this. So this is depolarization, and this is repolarization. Oops, got this mixed around. This is repolarization. And then this is depolarization. So the main goal really is to get the cardiac cell to go into a positive state so calcium can come in. Calcium is what's going to contract the heart, and then it's going to go back, reset, and do it all over again. And this is a really good diagram I found in terms of representing repolarization and depolarization. We're not concerned about the P wave. That's not what we're really looking at when it comes to this. As you can see, when depolarization occurs here, you have the spike again. A positive, when we're talking about depolarization that's going towards the lead, it's going to cause a positive spike up. And then it plateaus, which is why, and again, this little negative here is the kind of it going down initially with your initial repolarization. It plateaus, and that is your ST segment. And then repolarization occurs, which results in an upward bump in your T wave. So when we talk about repolarization, and again, this is all looking at a lead. If repolarization is going towards the lead, so a positive, it's going to create a positive bump on the 12 lead. And this is the electrical representation of what is the cardiac action potential. And this is exactly what gets affected when the cells get affected by a deprivation of oxygen. There's no oxygen that's going to the cells, and this whole system gets absolutely thrown out the window. Any questions so far? It's a lot to talk about, but it's essential that I kind of mention that, because when we go to the point where we're talking about how STEMIs are actually caused, it kind of helps to have an understanding of what the cardiac potential is. But heart attack, essentially the same thing as myocardial infarction, but it's more of a lay person's term. So most people know what a heart attack is, but when you talk about myocardial infarction, generally no one's going to really know what you're talking about. But when you have a heart attack, when you have a myocardial infarction, it's generally caused by a process known as atherosclerosis. So in the inner lining of your coronary artery, so here it could be any one of your arteries, which whatever cause it is, whether it's someone who's a long-term smoker or they have high cholesterol, um, in the inner lining of the artery, you have a buildup of plaque. And this is a process of atherosclerosis. So this plaque builds up over time. It's full of all these different things, these lipids, these fats, and it gets bigger and bigger and bigger. That's generally not an issue whilst it's still within this kind of enclosed capsule. But as it gets bigger, we generally start to see patients presenting. Oh, yep, you had a question? Yep, go
Yeah,
for it.
sorry, I just shoved loads of food in my mouth. Um, what was the difference between relative and absolute refractory periods on the diagram you just showed us there? Yeah, exactly that one.
So relative and absolute. So there are points here. That's a great question. Refractory period is basically a point where there cannot be another electrical impulse that allows the cardiac cell to contract. So in this period here called absolute, as it mentions, it it absolutely cannot do another process. So here, this process will happen, and in this process, you can't have another what another impulse from the pacemakers and cause another cardiac action potential to happen. So at this point here, it will continue its process um, with no other impulse allowed to cause anything here. But when it comes to relative, at this point here, there can be another one that occurs. And often we look at this point here as like it can also be masked as well. So when we have those very high tachycardia or like the SVTs, sometimes it gets masked because again, at this point here, you can have so when you have like really fast beats, the QRS still needs to the contraction needs to still occur, which is why we can see this, but the T wave can of course be masked underneath the next contraction. So basically, in very simple words, absolute means there cannot be another contraction, whilst relative, another contraction can occur, but generally it won't. But it can happen. Just really going back here, atherosclerosis again is your process of plaque buildup. When it gets bigger, and there's a lot, we talk about our risk factors, so people with diabetes, people with cholesterol issues, that's going to accelerate this atherosclerosis process. And as it gets bigger, we generally start to have patients with what's called as angina. So you still get blood flow that's coming through the artery, but because it's getting kind of through this narrow passage, it's starting to get less oxygen to the certain area. And the vessels, the coronary vessels are, when we look at the right diagram, they're kind of on the outer layer of the heart. So they're not in the ventricles themselves, they're on the outer side. And we're going to talk about the endocardium and the epicardial, and we're going to talk about transmural infarctions very soon. But when we start to get some form of occlusion through atherosclerosis, generally patients will just have angina initially. So when they're running or they're sitting, when they're exerting themselves, your body needs more oxygen. Your muscles and your cardiac cells, they need more oxygen. But because this area here in the artery that's affected isn't getting as much blood flow coming through, the oxygen demand is greater than the ability of the artery to provide that oxygenation. And so that's where we get our unstable and stable angina. Essentially, angina, when it comes to stable and unstable, we have I really don't say stable, but you can have stable and unstable. Stable essentially is when you have pain, like chest pain that happens when you're exerting yourself. So if you're going for a run and you start to feel pain in your chest, but you stop and it goes away, we generally call that some form of stable angina. When it becomes unstable and it falls under the acute coronary syndrome, is that you're getting chest pain whilst you're at rest. So it doesn't matter if you're exerting yourself or you're just sitting on your chair, you're getting some form of chest pain. And that generally means now that the plaque is getting very big. Potentially it has ruptured, but at the same time, it probably hasn't, which is why it kind of falls under when we're looking at the acute coronary syndrome. You can't really separate angina and STEMI fully without a blood test. But in saying that, as the plaque gets bigger and bigger, something happens. And that's why it's often a very quick process. You get a bit of angina and then suddenly everything falls through the window. The fibrous cap that's on the top of the actual plaque, whether it's blood pressure or some traumatic event or they've really overexerted themselves, that cap that covers the plaque that rips off. And the moment that cap rips off from this plaque, you now have what's a process of thrombus. So this plaque becomes thrombogenic, and essentially means that now that the inner parts of the plaque is exposed to the blood flow, exposed to all the clotting factors and whatnot, it's going to create a clot. Okay, things are going to bind into it. Again, very quickly, very simply, it's going to bind and it's going to create a massive clot in the heart, massive clot in the coronary artery. And so generally, once this cap comes off, and it can be very spontaneous, that's why it's very random when these things happen. Um, and it happens within within an hour or 20 minutes of onset. When this ruptures, things and processes happen, and essentially it starts to completely occlude the coronary vessel. And when it occludes the coronary vessel, the parts of the myocardium that are directly supplied by the oxygen of this artery will now be affected by it because it's not getting any form of oxygenation. And if you want to know, there's a few key things that happens once there's a full occlusion. So let's just say the plaque ruptures, and because this plaque ruptured, it's now completely occluded the artery. So a thrombus is essentially another word for a massive clot that happens in the artery. Once that's fully occluded, this area here that's directly affected by the clotting of the artery, these cells, these cardiac cells, no longer are getting any oxygen, and so you have a localized area, and this is exactly why we see only in certain leads what is a STEMI criteria, because the lead that's looking at the electrical activity of this one area that's been affected, it's going to see that the electrical system is getting it's not working properly. Whilst the lead here that's not affected, it's going to see a normal QRS and whatnot. But in this case here, it's going to see that, yep, there's something going on, and it's going to create a very characteristic pattern. But generally speaking, when you got an inclusion, when you got something that's happening where there's no oxygenation, there's a few things you need to be aware of that's happening in those areas that it's been affected. So firstly, you get a decrease in oxygen supply. This pen's not. There we go. Oxygen. You also have a case of acidosis. So the area around it becomes more acidic, and you have what's known as localized hyperkalemia. These are these are very important aspects when we're looking at this area, because that's what happens to that. When we mentioned the action potential, that's what's happening in that specific area that's been affected by the infarction or the heart block. You get a localized increase of potassium outside the cell, and as we mentioned, it needs to the actual cardiac cells themselves are negative, but you're getting more of it coming out. It kind of prematurely starts to contract before everything else. But we'll get to that point very soon. Acute coronary syndrome. This is what STEMI falls under. And God, my writing's really terrible. Sorry, guys. I've literally come out of night shift, so I'm trying my best here to do this presentation. But acute coronary syndrome is basically an umbrella term. But when we're looking at again the artery itself, let's just say this is the coronary artery. Hey, let's just say this is the left anterior descending. This is your normal artery. Okay, so it's fully open. There's nothing going on. You have a perfect perfusion of the area that it's supplying. Now we have a situation where a plaque starts to build up, and let's just say the plaque is around this point, and this is what we have known as your atherosclerosis. Let me just. So the plaque starts to build up and starts to kind of occlude the coronary artery itself, and this process is known as your atherosclerotic plaque. And this is also something that's called your fixed coronary obstruction. And this is your angina. So this plaque isn't going anywhere. It's probably going to get bigger and bigger. And this is generally kind of where we start to have patients with your kind of chest pain whilst they're exerting themselves. What happens here now is two things can happen. The plaque ruptures. What mainly happens is once this plaque ruptures, it's going to cause what's known as a thrombus. So it's going to almost either partially or completely occlude um, the coronary artery. But you also have a case, in some very rare cases, when it ruptures, it doesn't actually completely occlude the artery. So you have a case what's known as severe fixed coronary artery. So let's say it ruptures, but you still have an area that's getting blood. This is your severe. This is your severe fixed coronary artery. Coronary, sorry, obstruction. Oh, sorry, this I need to get a new pen. And this is also something we call chronic ischemic heart disease. So when the plaque ruptures, actually, sorry, when the plaque ruptures, if it heals, you end up with what's known as severe fixed coronary obstruction, so your chronic RDHD. But what also happens is that you can have a massive thrombus. So a blood clot. So when that, no, let me keep drawing this. When that plaque ruptures, a big thrombus forms around here. And you get two kind of things. You get your unstable angina and you get your STEMI. You can also get a full occlusion. And this is your worst case scenario. This is what's known as acute transmural. And this is your myocardial infarction. This is also known, so it's got a few names, also known as occlusive thrombus. And generally speaking, when we get to this point, that's when we're going to see this STEMI criteria coming up, is in this point where the coronary artery is completely blocked. So quickly going back to this kind of diagram, this is kind of the life cycle of a atherosclerosis plaque that ruptures, and it gets to the point where now this patient can potentially die if not managed early on. So normal artery, plaque starts to build up. At this point, it's your angina. Whatever happens, it can be a range of things, and which is why we look at risk factors. The plaque ruptures. Two things can happen. It can heal, so the clot doesn't fully occlude the artery, but it does severely now hinder blood flow. And this is what we kind of term our chronic RDHD or severe fixed coronary obstruction. The other one, which generally happens more often, is that when the plaque ruptures, you have a massive thrombus that forms. And generally speaking, you have your unstable angina, STEMI, or you have your occlusive thrombus. So generally with the thrombus here, it's going to be a lot smaller in terms of the blood flow. So I kind of didn't give it justice, but the blood flow here is very small. Small enough that the patient, if not treated, will potentially have a permanent damage to the cardiac cells. Does that kind of make sense? Perfect. All right. Now we know about the occlusion. Let's just say this is your artery that kind of sits in your epicardial area. So this part here is your endocardium. And this part here is your epicardial or epicardium. The reason why we often get STEMIs or unstable angina first before STEMIs is because when blood flow is coming through the coronary artery, it's going to perfuse the areas that's closest to the artery itself. When oxygen starts to get deprived, it's the areas that's furthest away. So your endocardium, which is on the edges of the actual myocardium itself. This part here will get affected first when there's no blood supply. So you end up with a localized ischemic area, and this is generally your unstable angina and your NSTEMIs. And this is important because this is why we get our ST depression in our NSTEMI kind of patients. Now, you can have this when it's still partially occluded, but once it's fully occluded, once this entire area of the coronary artery is blocked by plaque rupture, the area that it perfuses, so this portion of the ventricle, is now deprived of oxygen. And the moment it's deprived of oxygen, we call this a transmural ischemia. If you're wondering what the difference is between ischemia and infarction, ischemia is basically oxygen is being deprived to the cells. Infarction is when there is active cardiac cell death. And I do apologize. I don't think I emphasized the importance of oxygen in the cardiac cells. The cardiac cells, unlike a lot of things, so your myocytes do not regenerate. And this is really bad when it comes to heart attacks, is because once these cells die, once it goes from ischemia, so lack of oxygen, and becomes infarcted, the cardiac cells, so the myocytes that are responsible for contracting the heart, they do not regenerate. So even if you are able to reperfuse, so get to a cath lab and open up the area, if the cell is infarcted and there's necrosis, that cell will become what's known as scar tissue. And scar tissue is really bad because it does not allow any contractions. There's no action potential. It's just dead tissue. That's just covering the heart. And this is why we always emphasize the need for minimizing time on scene for STEMIs and all these kind of suspicions of heart attacks, is because the longer the cells are ischemic or not getting blood flow, the greater the chance of an infarction of the cardiac cells dying. And the more of the cardiac cells that die off and are no longer contracting, the greater the likelihood the patient is going to have hemodynamic compromise. So the blood pressure is going to tank. Oh, I really can't spell it after night shift. Sorry, I really am trying my best here. Dynamic compromise. So you have a drop in blood pressure as well, and you end up with these patients going into cardiac arrest because they simply aren't getting enough oxygen going through, and the blood isn't circulating. Because once a big portion of the heart contracts, or stops to contract because of infarction, the whatever chamber, and it's generally the left ventricle that's affected the most. Once the left ventricle has a part of the ventricle no longer working, it's what's known as heart failure. Or so if you were to, for example, perfuse this area that's been fully infarcted, but it's all dead, you generally have patients now, they will be suffering long-term effects of this, which is known as heart failure, and they'll have to go into medications because they'll have a reduced ejection fracture and basically inability of the left ventricle to perform as well as it once did. And so these patients will probably have to go onto certain medications to kind of compensate for that lack of cardiac cells that have died. Yeah. Oh, doing clear. So going back to what I've said, and I didn't realize I actually covered it in the next slide, but why is a heart attack serious? The heart, I just can't say this enough. The heart does not regenerate heart muscle tissue. Once it's dead, it's dead. There's nothing you can do. Scar tissue does not replace cardiac muscles in the same sense. Um, it creates a greater burden for all the rest of them. So every other cell's got to compensate because of the dead scar tissue, because of the dead cardiac muscles, and you end up with patients with reduced cardiac output, and they need to be on certain medications. In the event of a heart attack, you also have different other pathologies that manifest, and depending on where it is of greater concern. So your AV blocks and your syncope, so your faints, they generally can occur a lot more in your inferior infarctions or right ventricular infarctions. Your and hypertensive crisis that can occur in any of the types of ischemia that we have. APO very much can happen in your left ventricular, so your anterior infarctions where the left ventricle is being deprived of oxygen and you have cardiac cells dying. And of course, in any case of a STEMI, the chance of them going to cardiac arrest is high as well. So I always say if you've got a patient who is showing STEMI criteria and they got chest pain, I would definitely treat those patients as peri-arrest because you do not know at what point the patient will no longer compensate. And you also don't know what percentage of the actual cardiac myocytes are being infarcted. So it's almost like a guessing game. You're kind of watching them to see how they go. You have some patients that will immediately go into cardiac arrest, and some patients that will be all right all the way up to the cath lab. So it's kind of like a gamble when you're going to these kind of patients, how they're gonna be with you throughout your time with them. Quickly, heart attack isn't a cardiac arrest. They're not the same thing. Heart attacks relate to again the arteries become included, and you end up with no oxygenation to a part of the heart. Whereas cardiac arrest is the electrical cessation or the electrical activity ceasing to stop. You can have heart attacks that result in cardiac arrest. Again, it's killing off the cardiac cells. So eventually something's going to happen, and the electrical activity is no longer going to work. So, but cardiac arrest, they don't cause heart attacks, but they can cause clots. One of the things to note, and this is kind of like a side kind of good to know info here, is that after cardiac arrest, you have an increased risk of blood clots because, as we know, if the heart's not pumping and there's blood in the heart, since there's no movement, the chances of a clot forming in that time when the heart's not contracting is very high. And you can have a blood clot that forms in cardiac arrest. And if you were to get them into a ROS state, so their heart starts beating again, they could end up with a blood clot, depending on where it is. It can go into the heart, so they can also end up with a PE or a stroke after you've gotten them back. So, which is why a lot of patients, when they get a ROSC and they go to hospital, they're placed on some form of blood thinner like heparin as a precautionary thing. I'm sorry guys, this has already gone for 10 hours, often for 1 hour. So I'm just going to do a quick 10 minute, 5 to 10 minute break. If you guys are happy with that, because I have kind of spent a bit of time on those areas. Are you happy with that? Cool. I'll just give you guys a 10 minute break or 5 minute break, and we'll come back at 8:15. All right, we are back to it. I will continue on with the presentation because we still got a couple more slides left to do. But the acute coronary syndrome, I always say, especially when it comes to trying to make it easier to break it down, is it's an umbrella term. And essentially, from the one side of it, you have your unstable angina. Again, you won't really hear it being called stable angina. That's not really considered part of the acute coronary syndrome. That's almost like a pre-coronary syndrome situation. But generally, once you get unstable angina, it could mean that a plaque is ruptured or it's got to the point now that the plaque is occluding a significant amount of the coronary artery. In the middle, you have your STEMI. And there is a big talk at the moment about potentially moving these kind of labels into what's known as an OMI. You may have heard it from Dr. Smith on his ECG blog about how NSTEMIs kind of doesn't really capture um, the signs and clinical manifestations of other highly indicative ECG changes that correlate with an inclusion of an artery. But you have your STEMIs. STEMI is a big one. It's kind of directly telling you that, hey, there is potentially a full occlusion here, and this patient needs to be seen, otherwise they could die. Um, this one is very easy in terms as your ECG machine is going to show you that it's a STEMI criteria. Once you see it, you can say, yep, okay, you're having it. But these two, your NSTEMI, your unstable angina, you really can't differentiate with these two fully. I mean, you may get more indicative signs in your NSTEMI one, but to differentiate the two, you need blood tests. So anyone with chest pain should go to hospital because they need to get what's known as a troponin. And this is an enzyme that essentially releases when there is active cardiac infarction or ischemia happening. It gets released into bloodstream, blood circulation. And when this is elevated, it generally means that there's some form of blockage or ischemia or stress on the heart. So very simply, unstable angina by definition is persistent acute coronary syndrome or symptoms at rest. So your chest pain, shortness of breath, exertional as well, differs primarily in the presence or absence of detectable troponin compared to STEMI. So really, I guess a way you can kind of differentiate it is if you got signs of an NSTEMI with chest pain, then you kind of say it's more of an NSTEMI than unstable. Um, but not necessarily the most easiest thing to kind of separate with these two. Your NSTEMI, kind of like your STEMI, but same thing, unstable is persistent ACS symptoms at rest. You have ECG abnormalities, and I often like to say your OMI signs as well, but are not directly ST elevation. So because the ST segment isn't necessarily elevated, um, it's not going to be your STEMI criteria. And when we're talking about NSTEMI, these are kind of the things you want to look out for. So your pathological Q waves, your hyperacute inverted T waves, and of course your STEMI equivalents, such as your De Whelan syndrome, and all those, which I will show you quickly at the end of the presentation. Um, but there is a very large portion of patients that have NSTEMIs that actually have full occlusion of the coronary artery, but because of whatever reason, it doesn't present as a STEMI criteria. So these patients are often easily missed and don't get the treatment they need in a timely manner. And unfortunately, these patients get a very bad outcome because they spend time at ED and triage in the waiting room or whatever. They get the blood test, they realize something's going on, and by that stage, they've already had a pretty progressive amount of cardiac cell death or ischemia because they simply haven't been sent to the cath lab or had their care escalated because of it. Your STEMI, very easy one. Persistent chest pain. ECG shows ST segment abnormalities, and this generally indicates a complete occlusion to whatever coronary vessel that it looks after. And we can be suspicious of cardiac cell death at this point as well. So Time is tissue. The moment you see ST elevated myocardial function and you think it's related to acute coronary syndrome or some form of chest-related pain, these patients need to get to hospital. STEMI morphology, this is kind of a graph I created again a year ago now here, but generally speaking, they all kind of present in a similar fashion. Rule of thumb is the higher the elevation, the more it looks like a tombstone, like it kind of curves up, the worse the infarction, the worse the ischemia is. And generally, once it gets to that kind of tombstone effect, which we get often in our anterior infarctions, um, those patients are potentially not going to have a good outcome. So generally, tombstone, convex, saddle shape in appearance. The bigger the saddle, the greater the rodeo. So ischemia infarction is happening. Thing about STEMIs is that they evolve over time. Remember, it's an active occlusion of an artery. So these cells, they're not getting oxygen. They're only going to get worse and worse and worse as time goes on. So with these ones, if it's a genuine or it's a true STEMI related to a heart attack, we're going to see the ECG change as time goes on. So definitely continue to print multiple ECG strips to assess whether or not the the ST segment is going up or going down. Um, Sometimes you may have like a indicative signs first, so you may end up with either hyperacute T waves or inverted T waves. Um, it then progresses to ST elevation. In cases where elevation has been ceased or it's been fixed, you can end up with pathological Q waves that kind of show that there was a previous occlusion in that affected lead. But you can also have Q waves um, at the time of infarction as well. And the thing about interior MIs is that they're also called the widowmaker because because this affects the left ventricle, which is your in terms of the other ventricles, your largest chamber, it creates the most significant hemodynamic compromise because again, the left ventricle is pumping blood around to your body. If the ventricle is no longer doing its job properly, you're going to have multiple issues such as a backlog of blood into the lungs. You get your APO, as well as your massive drop in blood pressure and your cardiac arrests. So, what is a STEMI? Why do we care? Oops, I think I've already written here, but the electrodes record the electrical currents in the anatomical areas that they're placed in. So remember the different kind of views, so your horizontal plane and your vertical, they're all looking at certain windows of the heart to give us an idea of what's happening. When ST elevation in the setting of a thrombus occurs, it's a result of an injury of current secondary to acute ischemia. This is really important. Injury current is what we're going to explore and why this creates the ST elevation and depression. But it's this current that the ECG is kind of picking up as elevation and as depression. Again, infarction results in a loss of cardiomyocytes. These will eventually be replaced by necrotic tissue and scar tissue, and they do not depolarize or repolarize. And again, there will be no contractility in this scar tissue that replaces the cardiac cells. So once it's gone, it's gone. There's no way you can get it back. Um, and that's why we have a real ability as pre-hospital clinicians to make a difference in these people's lives. Because if you see a STEMI and you tell someone they're okay, they're going to trust your judgment because you are a healthcare professional. And you could potentially leave someone at home. You may lose your registration, but you could really make a significant impact by escalating care when you think there is something like this is going on. But with all infarctions, it can eventually progress to cardiac arrest. So just be prepared for that. Get your pads ready, and make sure you got additional support coming your way. All right, so this is the main part I really want to talk about today is your ischemic cardiac cells. And we're going to be looking at the action potential and how the STEMI, current injury, perfect, and how a STEMI may present because of the result of an ischemic cell. So if I draw a big circle, let's just say this is your cardiac cell. We mentioned earlier that in this cardiac cell, it is naturally negative charged, about minus 90 millivolts. Outside of the cell is mainly positive. Okay, you mainly got sodium outside the cell, and you've got some calcium outside the cell ready to go, and you've got potassium in the cell as well. If you have terrible, if your coronary artery here is is occluded, whether it's partial, it's fully, and it's affecting, let's just say this is the endocardium. Let's just start off with that, and it's affecting a portion of the heart. You're gonna have, as I mentioned, a decrease in oxygen, acidosis, and you're also going to have localized hyperkalemia in this area that's been affected. So what that actually means is that in this cardiac cell, because there's no oxygen, it's going to start impacting the ATP cells. It's going to start impacting the integrity of the cell membrane. We talked about ATP gated potassium and sodium channels. These channels are dependent on oxygen delivery to maintain them, to keep them closed, to keep them shut, and to help regulate and maintain that state in the cell membrane as a negative charge before the action potential. So what happens is this ATP ceases to work or function properly. And what you end up happening is, and in the next slide we'll see it, is these ATP channels, so your potassium channels that are controlled by your oxygen related ATP, they open up in these ischemic cells. And you end up with potassium, normally that should be inside the cell of these cardiac cells, they are starting to move out of the cell. And this is a really bad thing in the term of allowing a normal action potential to happen, because what happens is because the cardiac cell is having potassium coming out of the cell, these are positively charged ions. So when they leave, the cardiac cell is becoming less negative. And so what would be 90 millivolts initially in your phase 4 might sit at minus 50 millivolts or less than the threshold. The problem with that is when the cardiac cell is less negative, because there's more positive potassium now outside of the cell that's leaked out from it, you have a dysfunction or a shutdown of the voltage gated sodium channels. Because we mentioned in the depolarization phase is that there is a threshold, minus 70 millivolts. Because these cardiac cells, and we're only looking at these cardiac cells, because these cardiac cells are going to be less negative by the fact that the ATP channels and all those kind of things are leaking potassium out and causing them to be less negative, they're going to be not 90 millivolts, but they're going to be less than that. And they may be around 60, around 50, around 70. And the issue with that is because there's no kind of a gradual decrease into minus 70 millivolts, these fast acting voltage gated channels do not work. So the sodium channels that normally would come in very quickly, they do not. And so the sodium channels remain closed, the voltage ones, because they do not get that stimulus that gets to minus 70. And so you end up with these cells an earlier depolarization, because you still get calcium that comes in and potassium that's coming out. But depolarization is actually occurring earlier, and its repolarization is happening earlier. And you don't get a plateau in your calcium as well, because the whole system relies on a chain reaction event. So your new ischemic cardiac cell action potential is now happening earlier, and it's happening, and its depolarization is slower, and its also repolarization is happening far quicker than the rest of the normal healthy cells. So you end up with something like this. And the problem with that is it's only going to get worse until the point where the cardiac cell becomes necrotic and it dies out. Now, the reason why this is important, the reason why, because these cells are less negative and it's happening earlier because of its inherently less charged state, is that it's actually happening during our phase 4. So it's creating what's called a current of injury. And you think, why is that important? Well, because the leads that we use to look at the heart, their only role is to detect the electrical activity. So because this is depolarization is happening earlier than the rest of the ventricles, in that particular lead, it's going to create a charge when there shouldn't be a charge. And how that happens, if I talk about here, perfect. And now it happens, we'll explore in the next slide. But this is all happening in your phase 4. And again, this is only in the part that's affected, because if you look at, for example, lead 2 or 3 that is not ischemic, they're going to happen in its normal state, which is why when it's happening to those affected ischemic cells, we can detect it in those specific leads that are watching that happening at the time. So when we're looking at the current of injury, again, let's just draw our little coronary artery. And let's just say, let's start off with ST depression. How does that actually happen? And then we're going to talk about our STEMIs. Okay. So let's just say there's a partial occlusion, or an occlusion that isn't going to cause a transmural infarction. So you end up with what's called, so this area here is only a portion of the ventricle wall. And we call this the endocardium ischemia. Okay, so it's not the entire segment of the ventricle wall. It's only a partial part of it. Now, we talked about here that these cells are creating a net current of injury. Well, think about here. If we have a lead, let's just say this is V2. If we had a lead that's looking at the electrical activity that's happening here, there is going to be a current of injury. And where it goes is the current of injury goes towards the healthy cells. So the cells that aren't being affected. And how that happens is it's going to go this way. It's going to go down this way. It's going to go all to the good normal cells. And it's depolarization in the phase 4. So whilst every other cell is doing nothing, these cardiac cells that are ischemic and are less negatively charged, they're already depolarization process is happening in that phase 4. And you end up with what's called a net vector that goes towards the lead. So if it's going up and down, it's generally a greater depolarization towards the lead. And so how we mentioned as well is any depolarization that goes towards the lead is going to create a positive deflection. Now you wonder, okay, well, that's good to know, but recall how this is constantly looking at the electrical activity. So if we have an ECG strip, it doesn't detect like it doesn't take all this into account. And how that reflects is in a normal 12 lead or ECG, your QRS syndrome, you have like here, and then you have your here, and then your bump here. That's generally considered your 0 millivolts. But because it's seeing this current of injury in your phase 4 stage, where there shouldn't be any activity, there is a current of injury of depolarization going towards it, it's going to pick it up as ST depression. And how it does it is it actually elevates, because again, this part here is phase 4, and this part here is phase 4. This part here is your action potential of your myocardium. And so at this point, it's going to lift this up because, again, it's a positive deflection. It's going to lift up the phase 4 part up. So it's going to look like the ST segment is depressed. And how it looks is it's going to So what it should be around here, it's going to be your P wave. And then from here, you have a downward slope. Oh, and it goes back. Well, that's a bit, yeah, but yeah. And this is your ST depression. But it's actually picking up. This ST segment here is actually your isoelectric line. Because when the entire ventricle depolarizes, the net current of injury is zero. So there is no electrical activity. And that's what it picks up as. So here, the net current is zero. But because now, once it goes zero, and because the ischemic cells are now again depolarizing early and creating that current of injury, it's going to pick that up in the phase 4 part, and it's going to go back up, and it's going to look like the actual QRS is elevated. And once it depolarizes, it goes back to zero, and then it's going to go back up again. So you end up with your, oh, sorry, you end up with your ST depression looking like so. Does that kind of make sense to you guys? It's a bit of a difficult, can be a bit of a difficult concept to understand, but the um the lead is simply picking up in the phase 4 part the current of injury, and it's lifting up the actual rhythm as being a depression. So the ST will actually be the baseline, but because the rest of it's elevated, it's going to look like it's depressed. Right. Yeah. So now that we understand what depression is, and I think it might be better if we talk about elevation, that's kind of a lot more easy, I think, easier to explain. But again, same kind of thing. Um, in this case, the entire, let's write this out. Okay. So in this case here, the entire coronary artery is occluded, and rather than having some endocardial area infarcted or ischemic, you now have an entire portion of the ventricle myocardium being infarcted and having no oxygen perfusion to that area. And the same thing goes with your ions. It's going to be less negatively charged. You're going to have an earlier depolarization and an earlier repolarization. So in your phase 4, there's going to be a current of injury that the lead is going to pick up. Now the only difference is that with this one, rather than if we're looking at the current of injury, because the entire portion, and this is called your and this is your transmural infarction or ischemia, because the entire portion of the ventricle is being deprived of oxygen, and it's becoming hyperkalemic, and it's also becoming acidotic. Which way does the direction of the net current of injuries going? Well, it's going down and it's going up towards the healthy cells. It's not going towards, no longer going towards the lead itself because, again, the entire portion is affected. So it's going to go towards the sites that are healthy, and it's going to create a net current of injury in this phase 4 that's going away. So your mean average, so if it's going this way and this way, your depolarization is going away from the lead. And so depolarization, if it goes away from the lead, it's going to create a negative deflection. And so this lead is picking up that this net current is actually moving away. So this net current of depolarization is going away from the lead. It's going to pick that up in the phase 4 of the QRS complex and all that as a depression of the baseline. So how that actually looks is you get your P, and then from here it's going to go up, and it's going to go down. And this part here, your ST segment, is where the current of injury is equal to 0, because it says this is fully depolarized. There's no electrical activity happening, and then it repolarizes. This is your plateau. This is your plateau stage. But because it's detecting in phase 4 again that the current of injury is happening away from it, it's going to push the phase 4 part down on the ECG. So what happens is that it looks like on the ECG that the ST segment is elevated, but actually it's the P wave, and it's the rest of it that's actually been dropped down because of the deflection. As again, any depolarization that's detected by the lead is going to create a negative deflection. So they're negatively pushed down, and then once it's depolarized, it goes back to what it should be, which is 0, and then it goes back down again once it's been redetected. Um, that's kind of it for that one. Any questions in that regard? Did you want me to kind of explain it in a different way, or does that kind of make sense to you guys? You can just text me, send a message if you need. All right, okay. So we're going to move on from the reasons why we often see ST elevation depression, and we're just going to quickly go to the general criteria for your ST segment elevation. The J point in 2 or more continuous leads needs to be greater than 1 millimeter, other than your V2 and V3, because that's looking at more of your anterior, and generally it's going to have a lot more electrical activity happening, and that's where you get your bundle branch blocks happening, and your hypertrophies. So in leads V2 to V3, these are the following criteria that apply. So 2.5 in men if they're greater than 40, and greater than 2 in men 2.5 in less than 40, and then 2 males in greater than 40. Women, slightly different. It's 1.5 regardless of age. So a lot easier criteria for women. If they have any elevation in V2 to V3, that's 1.5. It's going to be STEMI criteria. Looking at some of the mimics, so pre-existing left bundle branch blocks, we do have a bit of a criteria here for it. So if we do suspect, or we do know there's a left bundle branch block, we can use the scarbosis criteria. There is a modified one, but essentially in the left part of it, ST elevation of 1 millimeter or more that is concordant with the QRS complex. So so that's referring to this part here. If this is elevated by 1 millimeter, and you also have a positive deflection of the QRS, we can consider that meeting STEMI criteria. Where there is ST depression in greater than 1 millimeter or more in V1 to V2, which is here, of the ST segment, and also where there's elevation of 5 millimeters or more, where there is a negative deflection. So if it's a negative and you're seeing a really deep QRS, we also want to count how, because it's going to, anything that has a negative needs to come up eventually. But if it's greater than 5 millimeters, then you can suspect that it's probably of an ischemic cause. And oftentimes, if a patient doesn't have a history of left bundle branch block, if it's in the setting of a new bundle branch block and they've never seen it before, that's also an equivalent to a STEMI as well. Briefly, reciprocal changes. ST depression on ECG is generally seen. We mentioned with the ischemia there, but it's generally the opposite side of the heart of the myocardial ischemia. So the absence of it does not preclude the presence of a STEMI. Again, we mentioned the endocardium. If that area has been affected, we're probably going to see some ST depression. Um, but it doesn't always need to be reciprocal, because we often say that if we see elevation in inferior, we should expect reciprocal changes, so ST depression in leads 1 and AVL, because these face the opposite side. But if you're just seeing depression in leads 1 and AVL, and you're seeing nil changes in the inferior leads, then this could potentially just be an end STEMI, rather than a full STEMI as well. So that's just something good to know. We talk about STEMIs and OMIs. So as I mentioned, about 20 to 30% of end STEMIs are found to have total occlusion. Um, and it's because of this that they often get a delayed cardiac catheterization, because we don't transmit those ECGs, they don't get their blood tests early, and they don't get seen by a cardiologist early either. And so these things do get missed. But there's been a big talk about moving from the STEMI criteria into the OMI criteria, so occlusive myocardial infarction. But again, there's still a lot of work in that regard. But when we're using the other interpretation, there have been times where cardiologists have been able to reclassify 28% of NSTEMI patients as having acute coronary occlusion that needs reperfusion, that needs a catheterization. Catheterization, yep. Just a quick exploration of that. So you have your occlusion myocardial infarction, so your OMI, and then you have your non-occlusion myocardial infarction, so your non-occlusive or sufficient collateral circulation to avoid an active infarction of the affected area. Just another thing to note, I went to one of these patients before. Silent MIs, they do happen. It's the presence of reduced oxygen-rich blood flow to the heart, same kind of pathology, but they simply don't have the STEMI criteria. So you don't see any real changes to the ECG. It's kind of doesn't happen very often, but in your patients, your other demographics, so females, you also have indigenous, and your other demographics, so culturally different. Those ones can present with silent MI, so just be mindful that not every patient that's having an MI, myocardial infarction, is going to have ST elevation or even NSTEMI. Of so I've already given you guys the cheat sheet, but I've created this kind of guideline in terms of what to look for when we're suspecting inferior STEMIs and anterior STEMIs. They're on the Education Hub link. You can download them for your own personal reviews and study. But generally speaking, when we're suspecting inferior, again, we're looking at the inferior side, so L2, L3, AVF. They're going to be elevated. And to put icing on the cake, if we're seeing depression in the high lateral leads, so your lead 1 and your AVL, that's kind of corroborating, kind of supporting the evidence that this patient is having an inferior infarction. So this one's a really good one because it's a nuanced one. A lot of people can miss this very critical and very crucial sign is right ventricular infarction, or your RVMI. Generally, you're going to have an RVI. If you're having inferior infarction, you want to assess for a right ventricular extension as well. And the way we can do that is doing a V4R to V46, but even just doing a V4R by itself will be sufficient. I won't show the lead, you can look up the lead placement itself, but it really doesn't take that much to do. And it does help indicate the significance in the extensive area that the infarction is happening. One of the criteria that we use is when your lead 2 is not as big as your lead 3. So if your elevation in lead 3 is greater than your elevation in lead 2, doesn't matter how big, if it's greater by 0.5 or 1 millimeter, you need to suspect a potential right ventricular extension of that inferior infarction. So if you're seeing lead 3, and you're already saying, wow, that's a really big elevation, you want to do a V4R. In the same sense, if in V1 and V2, if you have ST elevation in V1 and ST depression in V2, that's also associated with RVM. So double whammy, if you're seeing lead 3 is greater than lead 2, and you're also seeing elevation in V1 and depression in V2, you definitely want to go and do at least one V4R, which is simply moving one of your lead V4 and switching it to the other side. Septal, kind of self-explanatory, elevation, ST segment, that's in V1 and V2. The anterior, this is the big one as well. This is your widowmaker because, again, the area this involves is your left anterior descending artery, and this is your left ventricle that it perfuses. So if you're getting a massive infarction of that area and the cells are becoming ischemic or infarcted, the left ventricle is going to fail. And because it's the bigger chamber, it's going to have a bigger impact in terms of the patient's hemodynamics. So your lateral, elevation in your high and your low lateral, and you're also going to have reciprocal changes as well in your inferior leads. You do have all of these you can download, so you can just it's more of like just pattern recognition. We kind of now know what it means when it's depressed or elevated, but now it's just being able to recognize it. And this is one of the bigger ones as well with the right ventricular infarction, is that we don't always see it straight away. We have to be aware of things to look out for. This is not an STEMI. And this is why a lot of people get confused in, is that if we're seeing depression in V1 to V4, we should be very suspicious of a posterior infarction, because this area looks at the opposite side of the posterior wall. So we really should be doing a posterior lead placement when we're seeing any form of depression in these leads. So V7 to V9, we want to do, we essentially move this one, and this one, and we put them in the posterior lead placement. If we see elevation in these leads by 1 millimeter, that's indicative of an infarction, and that's indicative of a posterior infarction. And this is something you can't miss, guys, because these patients are having a STEMI. These patients potentially are having a full occlusion. And if you were able to recognize that and do the lead placement, you can then transmit this new V7 to V9 to the cardiologist, and you can get them to a cath lab. We will note that when you do print these out on a 12 lead, if you have done a posterior lead placement, you do need to cross these out and just write what they are, if these are looking at those specific leads, because you will confuse people, and they may mistake that as an anterior or of a lateral infarction. So just a quick little game here. If we're looking at this lead, we're only looking at the kind of the limbs themselves. We can see lead 2, there's elevation above the what is quote the isoelectric line. So we're seeing elevation in lead 2. We're also seeing elevation in lead 3. And we're also seeing depression in leads AVF and elevations in AVL depression and in elevation AVF. Already we can assess that there are reciprocal changes, and we are expecting that this is an inferior infarction, but there's also something to note. Inferior infarction, we have lead 3 that's greater than lead 2. So we can expect a potential right ventricular infarction as well. So we really want to do a V4R for this patient to assess whether the right ventricle is potentially impacted. Same here. We've got some pathological Q waves in V2, massive elevation, massive elevation. This is greater than 5 millimeters, so 5 blocks. Massive elevation here, elevation up here as well. This patient's having a full anterior infarction, anterior lateral. Again, you also got some elevation in V5, so you'd probably call this an anterior lateral infarction. And this patient's very sick. STEMI equivalents, we've already gone way too much over time, so I don't really go into full detail of them, but I do have some slides you can take a photo of a snippet. But essentially, these are all your equivalents that can suggest an occlusion of an artery that isn't necessarily on the ECG straight away going to print out a STEMI criteria. And as clinicians, we do need to be aware of these signs because they can potentially cause the patient to deteriorate, and they can potentially go into cardiac arrest without very rapid treatment. So again, posterior MIs, RVM. You also got your ST elevation AVR. This is also known as your forgotten lead with diffuse ST depression. So you're seeing multiple leads with ST depression, doesn't matter where it is, and you're seeing AVR elevation. Do consider that is potentially a STEMI equivalent. And if you're seeing elevation in AVR, I would say you should transmit that and get that reviewed. ST elevation in AVR and V1 with diffuse ST segment depression, that's just another one to consider. T-wave inversion in AVL and hyperacute T waves is another one to be aware of as an equivalent. I won't go into too much detail here because I just really want to go to clinical manifestations, but definitely feel free to just take a snapshot of these ones. Yeah, D winter TY is really hyperacute. Wheeling syndrome. Then you got your hyperacute T waves here. And then these are, again, your inverted T waves. So normal T wave should be upright. Again, a positive deflection when it's repolarization should be up. If it's inverted, generally it's suggestive of an ischemic injury from a delay in the regional repolarization. And we can consider it pathological if it's in multiple or 2 leads that look at the same area and it's greater than 2 millimeters. So this here would be considered a pathological Q wave. STEMI mimics ST elevation is not the only sign of occlusive thrombus. Again, I do? Wow. Okay. The issue with what I mentioned before is that it's not telling you, yep, you're having a heart attack. It's simply saying that the electrical activity in this part of the heart is not doing what it's supposed to do, or it's showing a difference to what is a normal baseline. And obviously, over time, we've realized there are patterns, and these are different variations that can produce or can print out a STEMI equivalent or STEMIc mimic. So your left bundle branch block, early repolarization, ventricular hypertrophy, pericarditis, so widespread ST elevation in like almost all leads. With chest pain, consider potentially pericarditis as well. Artifact, so the patient's moving, or if you're turn off beds. If they're on an electric bed, if they've got any electrical appliances nearby, make sure they're turned off. If they're on, very commonly, especially if you go to elderly homes, they may be on an electric chair that kind of moves and moves, so it moves and turns. So just make sure that's turned off before you do the 12 lead, and also your pacemaker. So that's your pericarditis here. And then you have your benign early repolarization. A very good one with left bundle branch block and ventricular hypertrophy. If you see really deep S waves, which is what these things are, so your QRS complex is negative deflected and it's almost touching or it's actually going into the other leads, be suspicious of either a left bundle branch block or left ventricular hypertrophy. Because if it's really deep, you're generally going to expect it to be elevated when it comes to the repolarization phase. Um, with left ventricular hypertrophy, it essentially means that the heart muscle in the left ventricle is bigger because it often happens in elite athletes. So those very young Ironmen or those who are Olympic competitors, they very well may have very enlarged left ventricles because again, because they're doing so much work, the heart's pumping a lot more than the normal person, and so their ventricle becomes thicker and stronger to kind of accommodate for that increased need of oxygenation around the body. Brugada syndrome, very characteristic look here, but can come up with ST elevation. All right, hopefully you take a photo of those ones, but let's just really talk about the clinical manifestations. Um, when we talk about signs and symptoms, really briefly, signs are what you see, symptoms is what they feel. The typical signs we may see in STEMIs and your ACS is just chest discomfort. So we want to assess if the pain radiates mainly to the left side where the heart is. Shortness of breath may be due to hemodynamic compromise or they're not getting enough oxygen around the body. Syncopes, particularly if it's in the inferior involvement, because where the inferior is actually perfuses, the right coronary artery actually perfuses the SA node, so the sinoatrial pacemakers. So when you get massive infarction in that area, it can affect the ability of the heart to actually pump, and you often may see heart blocks in your inferior infarctions as well. Excessive sweating, dizziness, so diaphoresis, often a pain response to chest pain. And this is also bad as well because when they're in pain, because of the ischemia and infarction, it's actually going to be worse off because pain induces the fight or flight response. So these patients, they're going to have an increased heart rate as a response to pain, which is going to increase the demand on the heart, which is actually going to accelerate um, the acute coronary syndrome. So it's a cyclic cycle when it comes to pain, and you also have dizziness. Atypical symptoms, they look very uncomfortable. They're very weak. Again, in your non-standard populations, they may have gas pain, back pain. Gastric reflux is a common one, especially if they have a known history. I went to one patient that had gastric reflux, or thought he had gastric reflux for about 2 hours. It was having a massive inferior infarct. Um, so that's often something that people mistake as just something that might go away. And then, of course, your other populations of female, young and old, indigenous, and diabetics. Big signs to look for is bradycardia. So, as I mentioned, your right coronary artery supplies blood to the right atrium and the right ventricle. It also supplies the SA node and the AV node via the septal perforating branch. As a result, when the RCA is affected by an occlusion, it can directly result in the dysfunction of the SA and AV node, and you can end up with an acute AV block. So these patients can be very bradycardic. They can present with complete heart block. About 5 to 10% of inferior MIs will develop complete heart block. I've seen this in person. And if you're seeing someone with complete heart block, they can also have presentation of a syncope as well. Cardiogenic shock, very common regardless of where the STEMI is, but very simply, if the cardiac pump fails and you have evidence of a tissue hypoperfusion, so you know the patient's having a STEMI or you know the patient's having a heart attack and they look sick, their cap refills greater than 3 seconds, their blood pressure's tanking, um, they got evidence of compensated shock, so heart rate's elevated, blood pressure's going down, or something of that nature. We should be considering cardiogenic shock. And I always would say that any patient with STEMI criteria, be very cautious of cardiogenic shock as an associated thing with it. Really simply put, this is essentially a failure of the pumps, the ventricles, to do its job. This leads to a reduced cardiac output, so not enough circulation to the body. This leads to a state of circulatory failure. So the pipes aren't pushing through enough circulation to perfuse the body. What happens then is that the body then begins to malfunction. You have the death of organs and tissues, hypoxia, hyperperfusion, and you'll often see that they become quite pale. One of the things that happens is when the body detects that it's not getting enough perfusion, the extremities, so the peripherals, so your arms and your legs, and your fingers, they start to shut down, so the blood can be rediverted back to the vital organs. Good to note, MI is affecting 40% of the LV, and the RVM will result in cardiogenic shock. And there's 3 stages. So you have your compensated. So in this case, when it's compensated, your heart rate's increased, and your blood pressure may either be the same or decreased. When it's uncompensated, the heart rate is down, the blood pressure is down. And when it's irreversible, it's basically uncompensated, but they're unconscious. And at this point here, they're probably in cardiac arrest. This one, big one to think about when you're going to your STEMIs that involve the left ventricle. So the MI affecting the left ventricle increases the risk of acute pulmonary edema. Decreased cardiac output triggers aortic arch baroreceptors, which in turn activate the rear angiotensin aldosterone system, and this increases the blood volume. There's a big issue with this is because when it detects that the ventricles aren't pumping, it's going to increase or try and increase the blood volume and pressure in the left ventricle to allow that circulation to continue perfusing the body. What happens is the left ventricle can't pump. It's not doing its job. It simply can't meet the demands because the cells, the myocardial cells, aren't doing its job because they're dead. What happens there is there's a backlog, a backflow of blood, because where does the blood come from when it enters the left ventricle? Well, it's come from the left atrium, and the left atrium comes from the pulmonary veins. And so where do the pulmonary veins go? Into the pulmonary lung, or sorry, into the lungs. And so what happens is there is an increased hydrostatic pressure as a result of backlog of fluid that's getting stuck in the left ventricle. And this results in fluid seeping out into the lungs and causing fluid to build up in the lungs as well. So you can end up with multiple issues with these patients, and it's good to be aware of them and to kind of think ahead if you're in the early stages. This is a really good diagram to kind of explain how this system happens. So let's just say here you have a decrease in ventricle emptying or ventricular relaxation, cardiac output drops, left atrium pressure increases, you have pulmonary vascular pressure increases, and then you end up with a cyclic chain that happens. And it gets worse and worse the longer this happens. I always say for these patients, especially if it's STEMI criteria and they look sick, is that they're at that point peri-arrest. And the reason why I say that is you really want to be on your game when it comes to these patients. You don't want to kind of play around and think, oh, if they look okay, they are okay, because you don't know what's actually happening in the heart at the time. There is no criteria for how long ischemia can go before the heart fails and cardiac arrest happens. Some patients are more tolerant, some patients are not as tolerant. It's variable. It all depends on how long it's been going for, the age, gender, size, and where the occlusion is actually happening in. As I mentioned, I've had some patients that are arrested on scene. I've had some that were arrested as we went to hospital, and I've had some who were really sick and actually managed all the way to the cath lab. So it's hard to gauge, but if you play it as if they potentially may arrest at any point, it just means that you're ready to go when the time comes. So talking to your partner, having a game plan, and knowing what things you need to do or what things you need to have ready in the event it does happen. So management, early recognition, and timely intervention is probably the biggest thing that we can do as clinicians in the pre-hospital setting. Time is tissue. Cardiac cells do not regenerate. So remember that time is tissue. You cannot regenerate dead cardiac cells. So the longer they're in a state of ischemia or infarction, the greater or the worse outcomes that's going to happen to these patients. Send the strip to the cardiology or receiving physician, have them review it, and if they're happy with it or they think it's serious, they're going to activate the cath lab, and you'll be able to expedite your transfer there. And STEMIs, ECG abnormalities associated with signs and symptoms. I would always say transport your unstable anginas in your NSTEMIs regardless. If they got chest pain, again, you can have silent MIs. You just don't want to miss these people because the last thing you want is to leave someone at home with chest pain and they end up dying. So I would always say if anyone has chest pain, you just take them to hospital. Big point, if they're really sick, you're overloaded, and you don't really know what to do next, just manage your ABCs. So your airway, and you hear a lot from everyone, is airway, breathing, circulation. Because any drop in one of these three is going to result in an arrest for a patient. So make sure the airway is actually open, whether that's positional, if they're unconscious, putting in some form of an adjunct to keep the tongue from occluding the airway. Breathing, again, make sure they're getting adequate oxygenation. You want to keep oxygenation above 94, but you don't want to over oxygenate. So again, just because you can actually cause a detriment if it's too much oxygen, because it has been known to cause vasoconstriction and worsen ischemia. So make sure it's above 94. If they're not breathing properly or they're unconscious, you may need to breathe for them. Circulation, blood pressure drops. You want to consider giving some fluids. And again, if their heart rate's really low, talk to your senior clinicians. You may need to get some medications prepared, like an adrenaline infusion or something like that. But always go back to your ABCs, go back to your principles. Um, don't overcomplicate it. There's always a case with these ones of analysis paralysis. Just go back to your airway, breathing, circulation. And as always, for your local protocols. Well, thank you guys. That probably went for a bit longer than I expected. That ends this webinar. If you want a certificate of completion, just let me know. And yeah, have a great day or great night.
Thank you.
Thank you.